Good afternoon, everyone. My name is Arissa Grant, and I'm the Risk Management Specialist here at Irwin Siegel Agency. I would like to welcome you to a webinar entitled Medical Malpractice Claims Alleged Negligence, Lessons Learned, presented by our very own Senior Risk Management Consultant, Sally Whittaker-Burquest. In a world where uncertainty is the only contest, risk management isn't just a safety net. It's a strategic advantage. This session is all about uncovering the hidden patterns, anticipating the unexpected, and turning risk into opportunity. During this webinar, Sally will be reviewing real malpractice claims to identify key risk factors with the lessons learned, real clinical case examples that focus on various concerns, practical strategies to strengthen an organization while preventing any future incidents, and last but not least, actionable approaches to enhance the quality of safety for organizations. Sally Whittaker-Burquest is a registered nurse and holds a Bachelor of Science degree from the University of Massachusetts, Amherst. She started her nursing career in women's health and as a neonatal nurse in Boston. In her current role, Sally works with clients across all lines of coverage on a variety of clinically related consultative services. With her deep clinical experience, she collaborates effectively with insureds, offering strategic advice and customized solutions. She strives to help mitigate harm in order to reduce claims, improve safety systems, and increase overall satisfaction. During the discussion, if there are any questions throughout, please submit them in the chat and we will try to address them at the end of the session. We're pleased to have you all here for this discussion. Please join me in welcoming Sally.
Thanks, Arissa. Thanks so much. As Arissa mentioned, today we're going to be talking about lessons learned from these events, claims and events that have occurred. And often when I'm doing risk management, I'm looking prospectively and things that we can do to prevent medical malpractice claims. And in this case, we're taking a retrospective look and looking at previous events that have occurred and seeing what we can learn from them. So let's go over the purpose and objectives. So first of all, to gain a better understanding of the medical malpractice claims that impact those with mental health and substance use issues. We're going to talk about that in more detail and also understand the risk management strategies that can be put in place to either prevent those claims or allow for better defense of the claims. Appreciate the significance of timely identification of clinical issues and prompt assessment. And I'm going to go into that in more detail. And I guess it wouldn't be a risk management program if we didn't have something talking about the importance of communication and documentation. So many times we go back to those issues, communication, documentation. And then last but not least, recognize how to determine what can be learned from an event and how to improve the system. I probably should do one disclaimer before I even start. I think because I had years of nursing, I tend to refer to people as patients. And I know not all people are patients, so I may use the term patient, I may use the term client, I may use the term individual, but it's just so that you know, I'm trying to break that habit. But any one of those terms, I think you'll get the idea. Okay, you can go to the next slide. Go to the next slide. Yeah, there we go. Okay, so when we look at the closed claims or claims that have a significant financial reserve for this book of business, there are really 5 lessons that to me really stood out as I looked at those events. First of all, complications of care occur. It will happen. And failure to appreciate the symptoms can exacerbate this situation. And I'll share some situations with you and some examples with you. Failure to follow the plan of care is problematic. Communication is key. Documentation is critical. Lack of documentation and altered documentation can significantly impact the defense of a case if there is litigation. And then last but not least, the review of the event allows us an opportunity to learn from the event and implement system changes. And I did a webinar just about a week ago, in fact, it was exactly a week ago, talking about a similar presentation for those who cared for individuals with the intellectual and developmental disabilities. And when I look at these claims that we're talking about today, there are fewer of the claims, but in some cases, the amount that's paid either for a settlement or for a jury award may be more significant. Some of the things that will go into play for that are, was this a professional, and what were they doing prior to this event occurred? Is it a sudden event that occurred, very unexpected? Were they the prime breadwinner for the household? Were they the caretaker? Do they have children? So all these things come into play, and particularly if it's a tragic event that occurred, it can have a significant financial impact. So I just wanted to mention that when we look at this particular group of claims. So when we look, you can go to the next slide. When we look at the complications of care, the first complication that we talk about is the medical problems that can occur. And what I noted in these claims were two areas stood out. It was eye problems and cardiac problems. And in both cases, there was a failure to appreciate the significance of the symptoms, so that the symptoms weren't attributed to anything significant until it was declared itself, and it was too late. It was a significant problem had occurred. So that was one piece. The other was medication-related issues. And sometimes being aware of the adverse effects of different medications, or the drug-to-drug interactions that can occur, or also being on the alert for self-medication and illicit drug use. That came into play with some of these events. But overall, it was a recognition of the medical problem, and again, responding appropriately and responding in a timely manner. So when we look at the risk management strategies for the medical and surgical issues, first of all, for the medical problems, you need to really look at being aware of what the individual's medical history is. Both is currently as well as previous medical history. As far as who's doing that intake, how is that assessment done? Is there a physical assessment? Looking at and being aware of the medical history and the impact that the medical history could have on the client's current care. The other thing is, what medications is the patient currently taking for medical problems? Are those medications available? If they're not available, how significant a problem is it? If you have somebody that needs medications for seizures, for diabetes, for hypertension, is there some mechanism in place to get those medications? Does the next team or next shift, are they aware of that plan? Sometimes it's just, the plans don't line up and the previous team isn't aware of that. So making sure that that's communicated. The other piece that we saw in some of these events is individuals that might have gone for care and treatment, say, for example, at a consulting care for an office visit, and there was supposed to be a follow-up visit, and it never happened, or it happened much later than it was supposed to happen. So that's one thing that's really important. If you have a client that has gone to a medical appointment or gone for some kind of consultation and treatment, if there's a plan in place for follow-up, really need to make that happen, or talk with that provider to make sure that it's okay, that if this is the typical one, that it's a Friday morning, you can't be there, is it okay to come on Monday? In some cases, that's not okay, and you have to make alternative arrangements to make it happen on that Friday. The other thing is surgical issues that can happen, and monitoring these patients after surgery. Some of the things you need to be aware of and need to make your staff be aware of. First of all, is there a dressing? I was a former nurse, and I know in taking care of post-surgical patients that it varies from physician to physician. If there is a dressing, what the plan is with that dressing. Some physicians will say, I want this off in 24 hours. Other physicians will say, don't touch the dressing. So it needs to be very clear for that provider and that patient what the plan is and what you're doing with that dressing. The other is there any wound drainage or any bleeding? And if there is, how are you monitoring that? In some cases, taking a marker and noting any bleeding or any drainage, and then noting the date and time so that somebody else can tell at a glance if that is getting worse, is it expanded, is it worse than it was? The other piece that we sometimes see is clients who may go for treatment and come back and they have, for example, a wound vac, or they have a wound that needs packing or something like that, that's not something that you typically do, that your staff don't feel comfortable with, you need to look at that and see, is it something that your organization is able to manage? Or is it a situation where this individual really needs to be transferred to a higher level of care? Now, when we look at some of the medication issues, I mean, some of it seems pretty obvious. You look at a client who has received a medication that they have a known allergy to. So you have to look at what are the systems in place within your organization to identify allergies. How is that flagged? How are people checking that? And are they checking that? But in some cases, we have patients who get medications, they have a known allergy, and it ends up causing a significant issue and ultimately a malpractice claim. So being aware of that system, how it's in place, and how it's done in your organization. The other is medications, and are they being given as ordered? Now, everybody does have a right to refuse medication, but to me, if somebody is refusing a medication, that's an opportunity for you. That's a red flag. It's a time really to take some extra time to try to understand, why is the medication being refused? Do they not understand something? Are they having a side effect? Is it interacting with another medication that they're on? Overall, the most important thing is to make sure that there's notification to whoever the provider was who had ordered that medication, so that they're aware that the medication is not being taken as it was ordered. And it may be that that's not a significant issue. Again, you go back to the meds like for seizures, diabetes, hypertension, and maybe that it is a significant issue. So just making sure that communication is clear. The other is being aware of possible side effects, significant side effects that can occur related to medications. For example, priapism is a prolonged and painful erection lasting more than 4 hours. And sometimes we see this related to antidepressants like trazodone or antipsychotics like Seroquel. It's a rare event, but it constitutes an emergency, a urological emergency. And one thing that you may keep in mind is time is of the essence in these situations. And due to embarrassment, the individual may not have said anything until the pain became unbearable. So your staff needs to be aware of this and to be aware of the fact that it is an emergency, it's serious, it's significant, it's a potential related to these medications. So a lot of staff education so that they're aware of the possibilities. Other medications may have other side effects that the staff need to just be aware of. Tremor, sedation, dizziness, different effects that may affect that patient or that individual, that the staff need to be thinking, wait a minute, is that related to the medication? Is that related to the dose change that we just did? Just to have them be aware of the possibilities and the most likely things that could occur or that they'd likely see with these medications. The other piece regarding medications, we always look at all the, it's funny, it's always been referred to as the 5 rights of medication administration, but it really is expanding because there are so many different issues that can come into place with medications. So we look and we see, is it the correct medication? Is it the correct dose that's being given? Is it being given at the correct time? Is it being given to the correct patient? And nowadays, if you're Joint Commission certified, they recommend 2 identifiers. It's often the name and date of birth, but 2 identifiers and to know what you're checking against to make sure that that medication that you're giving is the correct medication. Is it being given for via the correct route? Is it the correct reason for the medication? And then 2 that kind of come after the medication has been given. One is correct documentation and correct response to the medication. If the medication was being given for pain medication, did it work? Is there any comfort being provided, or is it not effective for this patient? As I mentioned earlier, the allergy flagging system, what's that system in place? Do individuals use it? Is it effective in being aware of what those safety mechanisms are? The other piece is the correct medication available. You need to be careful, particularly if you're ordering refills, if there are dosage changes. Sometimes we'll have situations where there's more than one dose available to that patient, and you need to, more than one dose. I was going to say that doesn't sound right, but it is sometimes more than one dose. So if you're titrating medications, there may be more than one dosage available, but you need to make sure that if you do have different dosages, that is the correct dose you're giving to the patient. It's funny, I had said last week, I was talking about that, you very rarely would give more than two pills at a time, 2 tablets. It's pretty uncommon that you would have more than 2 of a medication that you're giving. And just this morning, my husband was going to the dentist and was taking 4 of his antibiotic, and he was saying, "Is this right? Am I supposed to be taking 4?" And I went back and looked at it and said, "Yes, that is right, but it's good to check." But it is unusual. So that if the staff is calculated and they've said, it's 6 pills that need to be taken, they should be aware that that's a red flag. It's like, wait a minute, let me go back and see, is that really right? Is it really more than 2 that should be taken? Staff also need to be aware of medication changes. And as I mentioned earlier, what are the possible side effects that can occur with these medications? And then if they occur, who do they notify? What are they supposed to do if they see this happen? Is it something that they can wait until the morning or wait until the weekend to let somebody know? Or if this happens, they need to be letting someone know right away. They need to be aware of the different range according to what's happening and what medications. And then last but not least, we look at medication reconciliation. This is really kind of I think of it as kind of a step back, a big picture look to see on a periodic basis, what medications is this patient receiving? How many medications are we giving this patient? Are there drug-to-drug interactions that are playing a role here? Are there medications that are really doing the same thing? Is there any way we can change this so that it's better for the patient, so that it's safer and it's more effective? So sometimes initially when a client comes to your organization, maybe when they've come back to your organization, or even if they're with your organization for a long period of time, there needs to be that kind of a step back look to say, what are the medications we're giving? Is that appropriate? Is that what we mean to be doing? And making sure that the medications are appropriate. We have had situations where there's a respiratory depression that can occur because of one medication versus the other. So knowing the big picture and being aware of the meds is important. The next slide just talks about the differences between medication side effects versus an adverse drug reaction. And sometimes you'll hear both of these terms. So I kind of like this slide because I thought it was very simple and easy to understand. A side effect is often predictable. It can be beneficial, but it also can be just kind of a neutral thing, or it can just be noted. Typically, it does not require discontinuation of the medication. And I think a common example is, for example, Benadryl. It causes sleepiness. It's just kind of a known, it might affect you that way, and it sometimes does. As opposed to an adverse drug reaction, which tends to be unpredictable. It occurs with normal dosing and during proper use. It tends to be more serious than a side effect. It can be severe and can be life-threatening, and it results in immediate cessation of the medication with need for appropriate treatment. An example of this is a medication that causes some type of anaphylactic reaction. It needs to be stopped right away. There needs to be treatment rendered for that situation. So I just like to explain that because sometimes you'll hear both of those terms. So that's kind of a nice way to think of the situation. The next slide talks about the second issue that we see, or the second lesson that we can learn from, and that's from failure to follow the plan of care. And for this book of business and for these clients, the situations that we're most frequently seeing are regarding frequent checks and rounding, signs and symptoms of withdrawal, and then being alert to a client who may be depressed and expressing suicidal ideation. And so whenever these events occur and whenever we're looking and talking to organizations that provide this care, we're always asking about the standardized assessment tools. How are you assessing for this? Is everybody doing it the same way? How is it being handled if you have somebody who is, for example, at risk for suicide? And on the next page, I'm going to just talk about, so we talk about the different policies that are in place for your organization. A great deal of my job currently is looking at different policies and procedures. And it's really important. They need to really be the heart of your organization. And staff need to be aware of your policies. They need to be compliant with your policies. So if there is care that's provided, say, for example, we have a situation where the frequent checks weren't done as they were supposed to, or the rounding wasn't done. You know, one of the first things we'll talk about after that event is, what does the policy say and how frequently, you know, are you supposed to do that? Now, if all of your staff are saying a different thing, or people are saying, well, I don't know, nobody ever told me when I started, or I always thought it was supposed to be this way, it needs to be standardized. Everybody needs to know it. Everybody needs to be compliant with it and handling it the same way. If you're not seeing that, if there's non-compliance, then how is that handled? How do you address that? And we'll talk a little bit more about that. Sometimes if I'm aware of a situation where there is non-compliance, if we've had an event that has occurred, some of the organizations that I've worked with have done spot checks in the middle of the night. They will come in at 2 a.m. and they will do spot checks, look at the documentation to that point, and see if there's documented checks being done. Other situations will have a supervisor come around and do real-time checks in a similar way by a supervisor. We have other organizations that have gone to technology, that are using like Observe Smart software and scanning systems, and using technology to help play a role in that, to both improve the compliance with the monitoring that needs to be done and with the documentation. The other piece I think that you need to look at if these types of events occur is, did staffing play a role? And if you feel that staffing did play a role, then addressing that and seeing, what is the plan B? How are we going to, if this happens again, do we have mandatory overtime? Do we have per diem staff? Do we have agency staff we can call in? How are we going to address this if it happens again? I think related to this, we sometimes have situations where a client is very unexpectedly found unresponsive. And we've had different varying responses from the staff in regards to CPR and in regards to emergency procedures. You know, the staff may have CPR and first aid training, but do they feel comfortable doing it? And obviously, it's going to be nerve-wracking anytime a situation like this happens. But you may need to have drills, you may need to have role playing, you may need to walk through or talk through exactly what to do if these events occur. We've had situations where the employees are calling the supervisor instead of performing CPR. So, you know, we need to really make sure that even if it's an event that happens very rarely, that staff know how to handle it and know what to do in that situation. The other piece I would just say about policies is they can be useless if they're not referred to. And some of the situations I've seen, in fact, I know one place where I had worked previously, we had an emergency response policy that was 30 pages long. And it was so difficult because if there was a true emergency, you did not have time to flip through 30 pages and find the exact event that was occurring. If you've got policies that are out of date or they're inaccurate, so that staff say, well, you know, I'm not even going to look at this because that's not right. You know, so you need to make sure that the policies are reviewed periodically, that they're up to date. The other thing to be careful of is if you have policies, for example, that are online, but either people are printing them off because it's just easier to find it if it's in the file folder, or maybe it's a combination of online and paper. You need to just be sure that if you've got a combination of both, that if, for example, the online policy gets updated, then you need to make sure that that paper policy is updated so that you don't have two versions of the same situation. That is also a situation that occurs. The other piece that we've seen is, this goes back to when it was paper policies, but an organization that had them all locked in an office. So if it's 2 a.m. and something happens, you can't get into that office. That's not going to help those employees. So just being aware of where the policies are, access to the policies, are they used, are they referred to? One of the best ways, I can keep going on about policies probably for about an hour here, but one of the best ways that you can really do this in your organization is every month, as part of one of your meetings, just have a review of 2 or 3 different policies and go over them and see if there's anything that needs to be changed. And that's an opportunity to just take a time out, have staff participate, and it allows them to really talk about the policies. How do they usually handle it? It's a good way to, it can be very challenging, but because everybody can sometimes have their own thoughts and beliefs, but it can be a good way to make your policies real for your organization and make sure that they're current and up to date. The next lesson that we learn is related to communication, and communication is one of the areas that, again, we could probably talk about for the full hour, because there are just so many different aspects related to communication. Sometimes what we're seeing in the claims is relating to something that happened on maybe the previous shift or the previous day, and the current staff they just know nothing about it. So looking at the handoff that happens, how that information is communicated from one staff member to the other so that there's awareness of that event. The other is communication regarding failure to inform medical personnel, and that can be different within the organization. It might be a supervisor, it might be a nurse in the organization, a nurse on call, medical director, PA, nurse practitioner. Sometimes there's just a hesitancy. Maybe staff is intimidated to call these people, but sometimes we're seeing that where there's a failure to inform medical personnel. Failure to timely refer for medical care. Sometimes there's a need to just get that person, dial 911 and get that person to a higher level of care. And I think that in going back to policies, what I've seen in some of the policies is very clear specifics with indications indicating if these symptoms occur, call the supervisor, call the physician on call, something like that. If these symptoms occur, then the client needs to be transferred immediately, call 911 and transfer the client. So sometimes it's again goes back to a lot of education for the staff, but making sure your policies are very clear as far as what the expectations are for what happens. The other piece that we see is failure to notify the family. And I'm going to talk about that more in the next piece. But sometimes that's a difficult situation where you don't want to scare the family or upset the family if it's 2 o'clock in the morning, but yet there is a need to notify them about something that has happened. You can go to the next slide. So the risk management strategies that we see for communication, first of all, looking at handoff and that communication from one shift to another in your organization. How does that happen? Is there an opportunity for face-to-face communication and conversation? Is there an opportunity to share concerns and answer questions? And are the key concerns shared? When we look at notifying clinical staff, again, as I mentioned earlier, do your policies specify what are the written specifics and what are the examples of when you absolutely need to call? The other piece is to be sure that you have a culture where those calls are encouraged and accepted. I know as a risk manager working in a healthcare organization, I had a situation with our corporate attorney that I could call him literally at 2 a.m. with a question. He might not be glad to get a call at 2 a.m., but he would always answer the call, provide advice, provide guidance. And you can bet if somebody is calling and they're getting yelled at or barked at or not getting the information, they're not going to want to call again. So I think that you need to look at the culture for those calls. Are they encouraged? Are they accepted? If you feel like you're getting calls ridiculously, there, again, it goes back to the education as far as educating people about, when to call, what different situations and how they can be handled. The other piece that we sometimes see is if there's been a virtual assessment, there are times if there's a disagreement regarding an assessment and how things should be handled, what the plan should be, there are times when it's best to come in and do the actual, if possible, come in and do an actual hands-on physical assessment. So if there is disagreement or if the on-site person is concerned, erring on the side of caution and making sure that that individual is assessed. And then overall, regarding all those conversations, is making sure that there's documentation of notification. And that would always include the date, the time, who was the one that was notified, not just, physician on call or supervisor on call, to have the exact individual, the name of the individual who was notified. So if it is 2 years later and you're looking at this, you'll know exactly what happened and exactly what the situation is. Regarding referral, I jumped ahead. Policies regarding notification of the family. So what do you do if it's 2 a.m. and somebody has fallen out of bed? I would recommend that even at 2 a.m., you notify that family. Now, I would recommend that there be some introduction to this up front so that the family's aware that they may get a call if something happens. Our policy is that we are going to notify you. Hopefully you can, it's not going to be something significant, but if it is, it's important to let them know. As far as who should do that notification, that's going to vary, I think. And what I would suggest is that there be almost like a little huddle to decide who is the best rapport with this family or with this client, who has a good understanding of the situation. Particularly if you don't know exactly what has happened, you need to have somebody who can explain clinically what may have happened, what is being done, to reassure that you'll keep them informed as to what's going on. You don't want to overpromise. You don't want to speculate and guess as to what has happened, but it may be the first in a number of conversations if you don't clearly know what has happened to the individual. Again, in those situations, you want to be clear that you're always documenting names, dates, times of all the conversations that occur. It's important to have all that information. Regarding referring for medical care and treatment, I mentioned already about having your policy be very specific, but also I think the education and training, if you are using equipment like an O2 saturation or pulse oximeter monitor, does staff know when is it low versus when is it critical? Oftentimes, if you have an O2 sat that's 93, 94%, that might be low, but if it's below 90, below 92%, then that's the need to take action and do some further assessment as to what's happening. Monitoring an individual until the time of transport, particularly if you have a client that you were concerned for suicidal ideation, you need to have somebody with that individual until they're able to be transferred to a higher level of care. You don't want to be making arrangements for that transfer and have them ultimately commit suicide. The other piece is you want to teach staff to trust their gut instinct. And so many times when I was working as a risk manager and talking with individuals like after an incident report had been filed, I would be talking to them about the event and they would say, I knew I should have called. I knew I should have let someone know about that. And so many times our gut instinct will kind of kick in. And it's funny, I was reading an article earlier, and it happened to be about Warren Buffett, who is 95 years old. And he was writing and kind of reflecting back on his life. And I was surprised. He said that he was 95 years old. And in thinking about it, was kind of surprised that he was sitting there at 95 years old, because at a very early age, and he went on to tell the story, that at 8 years old, he had almost died. And he talked about how he had abdominal pain. A physician had come to his house, had palpated his stomach, had told him he thought he'd be fine. He'd be good in the morning. And the physician that night had gone home. He'd had dinner. He was playing cards, and he kept thinking about the assessment he'd done earlier. And as it turned out, Warren Buffett ended up going back in the middle of the night for an emergency appendectomy. It sounded like he was pretty sick after that. And I thought that's such a good example of that gut instinct kicking in. You know, you're off doing something else, or it's just kind of nagging at you. And the employees will feel that, and encouraging them to take note of that. I used to do new employee orientation. I mention this in every new employee orientation so that employees would realize the significance of that, that if they started feeling that something wasn't right, to trust that gut instinct, not to just say, well, I'm new, or I don't know, maybe that's not right. Trust that. And it may be that they can be reassured, but it's important to follow that. The last piece about referring for medical care and treatment is responding to requests by the client or by the family. And I think this is particularly important if you have an individual who may have been at another setting and they come to you and things maybe aren't exactly right, but you're trying to reassure them that everything is fine, and they are just relentless, that it's not right, that something doesn't seem right, that this isn't right or that isn't right. If it's something that clinically could be a concern, that may be a red flag that it's best to get this individual assessed, have somebody assess them, transfer to an ER, somehow allay their concerns if it could be that that a complication is occurring. So many times we see that lawsuits are filed related to anger at a situation. Lots of people will think, oh, they just wanted to get money, or they knew that they're sitting on a golden goose egg. But lots of times it's that they felt anger, that they wanted to have a better understanding of exactly what happened. Maybe they still have a lot of questions. How did this happen? Maybe when you talked with them, things seemed fine, and then they've talked to other family members or friends who rehashed different questions in their mind, or they don't want it to happen to anyone else. So again, we go back to that communication and just, you know, listening to that family if they're kind of relentless, and just, you know, trying to step back and look at the big picture and say, is there a need to perhaps transfer this client and get them checked out in more detail. The next piece is related to documentation. Documentation is critical, and some of the areas that we see documentation come into play, we go back to, you can go back actually to one previous slide, but we look at lack of documentation. For example, a client who's fallen and there isn't documentation in the medical record. I think that as risk managers, we've said for years not to document that an incident report was created, and that is correct. However, the event itself does need to be documented in the medical record. If there's inconsistent or missing documentation, looking at the frequent checks is an area that we see this happen for those with substance use and mental health issues. And some of the things that we look at there are the ongoing audits, or as I mentioned earlier, on the spot correction of the problem and addressing it and dealing with it. Incorrect or inaccurate documentation. It might be weights, it might be blood pressure, blood sugar, or it could be documented checks. And sometimes what we're seeing is, or what we have seen in some of our claims, is a documented check at 7 a.m. And then we see subsequent documentation that the client was found unresponsive at 5 a.m. So then you go back and you say, okay, you know, how did we get a documented check at 7 a.m.? So it, you know, all of that goes into play in defending the care and treatment that's provided, and make it very difficult to defend if we can't rely on the documentation that's in the medical record. The other thing that we sometimes see is inappropriate documentation. I remember when I first started doing risk management, I would go to physician offices and look at different areas in the office where they could get sued. And at that point in time, they were using paper medical records. And I was reviewing these medical records, and every once in a while, I would see in the very corner of the medical record, it would say PIA. And I said, what's PIA? And you can guess what PIA was. I said, you can't have that in the medical record. I mean, that was their own little code to themselves, but you cannot have that kind of inappropriate documentation in the medical record. So there needs to be education, if you see that kind of thing, as to what is appropriate, what is objective documentation, what are the ways to document something in the medical record. Delayed documentation. Sometimes, particularly with electronic medical records, if we have a system that's down or we have a provider who's come in to see the patient, then we have delayed documentation. It's important that that gets in there as quickly as possible so that other care and treatment that may be depending upon that is in the system. The other piece to that is knowing what the policies are for documenting from a timeliness perspective, about the importance of not documenting something ahead of time and not documenting something if it's a significant amount of time afterwards. We sometimes see issues with altered documentation, and if it's 6 months after the fact, you don't want to be changing that medical record. That would be something to either talk with your attorney, talk with us, talk with someone in claims, and say, you know, this is the situation, this is what we've discovered, what should we do? No matter how tempting it might be to just make a change, you know, we've seen that with whiteout, we've seen it with changes that have occurred, but even with the electronic medical records, plaintiff attorneys will request the log to see changes that were done and the date and time, and look at those changes that were done for all the transactions. So it's important to be aware of that and to not be altering medical records, because it can, even though you may think, well, we did this, we need to include it because it's important to know if it's going to be detrimental to defending a case, then you need to talk to us before you go changing that medical record. Okay, let's see. For lack of documentation, the other piece, if you can go back go earlier to one slide, I think. For the lack of documentation, again, having staff know when to document, how to document, what to document. The other piece to that is being available to help and to advise them. I always think back to an event that occurred when I worked as a risk manager in a hospital, and everything ultimately was fine. But during a breathing treatment, the respiratory therapist had dropped a 2-year-old child. And I went and looked at the medical record, and I knew that a resident had come to assess the baby after this had happened, and the baby was okay. But the resident had worked all night long. The resident was exhausted. The resident had done the assessment and just left, never documented it. So I was there with the nurse, and we were talking about the event itself and how that should be documented, how the assessment after the event had occurred, that need to be documented. So sometimes there's a need to help, because we're not perfect. We don't know sometimes. And again, if we can help with that, we would be glad to, not that we know the magic answers, but we would be glad to help put our heads together and assist you with that. I think everything else I've talked about as far as the documentation there. So you can go to the next slide. Okay. Importance of knowing the patient. This is what I was talking about earlier, really about knowing what happened on the previous shift or the previous day, or just being aware of the events that have transpired, reviewing the record, reading the previous notes, being aware of concerns or care and treatment, things that have gone on. Written policies, again, being aware regarding timely documentation or corrections or additions to the medical record. It should spell out in your policy if it's more than 24 or sometimes 48 hours after the fact, that medical record shouldn't be touched. If there are other changes that need to be made to the medical record, it may be noted somewhere else, an incident report or something else. The other piece regarding documentation is to just be aware of what are the record retention laws for your state. And it may vary from financial records to employee records to medical records. But you need to be aware of both for complications, complaints, concerns, that type of thing. How long do you need to keep those medical records? The American Health Information Management Association can be very helpful in that regard. And then also, if you are destroying medical records, keeping a log so that you know what was destroyed, when was it destroyed, how was it destroyed, having that information so that you have some type of reference, you have some way to look back at that. The other piece that we haven't really talked about is video footage. If there is an event that has occurred, have you reviewed the video footage? Has it been secured? And that's important. And you know, if you don't have a medical record or you don't have the video footage, or somebody refers to video footage and you don't have that, it's very difficult, and it can, if you can't produce the medical records or videos and there is litigation, that can jeopardize the defense of the case. So you want to be sure that you've got that information, you've got it secured. If you have concerns about it, if you have something on that video that you have concerned about, or you have something in the medical record that you have concerned about, be sure you share that right up front. First thing, if you have an attorney who's providing your legal defense, or a claim representative who's working with you, make sure that you are sharing that with them if you have any concerns about that type of thing. And last but not least, when we look at the sixth lesson, it's the review and response after an event has occurred. And I'd just like to read this quote. This is from the physician who's the president and CEO of ECRI and also the Institute for Safe Medical Practices. And he talks about, too often healthcare professionals are punished for being human. This drives fear, suppresses error reporting, and ultimately puts patients at risk. We must create environments where people can speak up, learn from mistakes, and feel supported while doing their jobs. The focus must shift from determining who is at fault when errors happen to determining what went wrong, what can we learn, and how to improve from the system overall. And that's what actually, I was reading something else this morning, and that's actually what got me on to Warren Buffett, because Warren Buffett, in one of the last letters he wrote just on Monday to his shareholders, was talking about learning from mistakes. He said, don't beat yourself up over past mistakes. Learn at least a little from them and move on. It's never too late to improve. And I think that is so important to remember, is to look at these events, see what we can learn from them, see how we can share them with others. We want to maintain confidentiality. We want to not jeopardize things for employee confidentiality, but yet if there is a way we can share the event and share the learning opportunity, that's important. So let's look at the risk management pieces related to that. Sometimes what I see, I think if you go to the next slide, sometimes what I see when I'm talking to an insured after an event has occurred, I will sometimes say, you know, what did you learn, or how did you handle that event? And they said, oh, all the staff were terminated. Everybody who was involved with that was terminated. Well, that might have been the appropriate thing to do, but it might also have been a knee-jerk reaction to a tragic event. So I think you need to look at each event and ask yourself about systems issues and about the safety issues that come into play with the event. And is it just the fact that that employee happened to be involved, but it could have happened to any one of us? So really looking at your organization and seeing, you know, do employees report only what can't be concealed? Are they only telling you about things that that you know, you can't hide any longer? Do they report only the state reportable events? While those do need to be reported and followed up on that perspective, the state reportable events is really the minimum situation. You want to look at the events, whether it can sometimes be complaints, it can sometimes be incident reports, events that get shared with you that allow you an opportunity to just to really realize that they may have prevented something serious from happening. Some organizations have even instituted what they call a great catch program. And maybe every month or every quarter, they'll take one of those events, whether it's an incident report or a complaint or an event that occurred where the employee's role and the employee's actions helped from making that event be significant. And sharing that story, and not only makes that employee feel awesome and gives them the recognition that they deserve, but it also lets the others in your organization know that you value that and that you take these issues seriously, you want to prevent them, that you want to do the right thing. The other piece is you want to avoid turning a blind eye to risky choices simply because no harm occurred. Again, is it something that maybe we were fortunate this time and there was no harm that occurred, but maybe next time we're not so fortunate? So, I think you need to look at the events that get reported in and the events that you hear of and that you know of, and really dig down in to see, are there things that need to be changed that you can learn from and that you can change. And then again, just overall, just realizing that if you have a punitive culture, that is really going to, in the end, undermine patient safety, erode trust, and increase the burnout for the staff. So you want to use these events as learning opportunities. You want to appreciate staff when they report them. I know I've talked with some organizations that, if an incident report was submitted, it was, that person was written up and that was starting a termination. And there may be times that that's indicated, but that also can be indicative of just a knee-jerk reaction that makes you feel good, makes you feel like you've taken some action to the event, but it may not be the correct action that needs to be taken. It may not be ultimately correcting the problem that's at the root of the situation. So I think you need to always be aware and looking at the big picture. I think that is the end of the lessons that we've learned today. I think we do have a couple of minutes if anybody has questions. I don't know, Arissa, if any questions have been submitted, but I'm happy to answer any questions that you might have.
Thank you, Sally. We do have a couple of questions since we have some time. The first question we got, we don't really receive any incident reports from our employees. We always assumed that it was a good thing. No news equals good news, but is it really?
That's a good question. I'm laughing because I worked at a hospital as a hospital risk manager, and I would get the incident report. So I would be tracking the incident reports and how many came in from the ER, how many came in from ICU, how many came in from this floor, that kind of thing. And I'm not getting any at all for like 6 months from the ICU. Now, because of the high intensity of care that's going on in an ICU setting, intensive care, that events are happening, or at the very least, near miss events are happening. So it is, that was a situation where it was concerning. I knew events were happening, and you'd know that events were happening because you would maybe be hearing complaints or you'd be hearing lawsuits, and you're thinking, I didn't know that. And it's information you're not aware of. So if you're not receiving those events and you feel that they are happening, that's really a need to do some self-reflection and really see, how am I responding to these events? Am I giving the message, maybe directly or indirectly, that I'm pissed off and I don't want to hear about it, and I'm, you're out, or whatever action it is. I think that you need to take some reflection to say, are we really using these events to be a catalyst for change, to be really looking at why something had happened and what we can do to prevent it from happening in the future? That's a good question.
All right, thank you, Sally. We have another one. Who is responsible for the medication reconciliation process? Is it the nursing staff, the physicians, or our pharmacy?
Medication reconciliation is really kind of it's an interesting process. To me, it's really a shared process, and I've seen it happen where actually all three of those individuals would be involved. Oftentimes, the nursing staff or whoever's doing intake may be getting some preliminary information, maybe getting all the bottles and the prescriptions that the individual is taking. The pharmacist may be contacting other pharmacies to say, you know, we're caring for this patient, and, you know, what are the medications that you have for that patient? And then to the physician or the provider, nurse practitioner, PA, is the one that would be looking at the big picture, taking all that information that's gathered by nursing, by pharmacy, by other staff, the client, the family, and putting it all together to say, you know, let's hold this medication for now. Let's stop this medication. Let's continue. Would they make the big picture determination as to how to proceed forward? But oftentimes it's with the input from others in order to get the final picture and the big picture of all the meds that the patient is on.
Thank you, Sally. We have one more for now. If there is a significant event that occurs, for example, a fall with injury, should we report that as a possible claim or wait to see if a lawsuit actually gets filed?
That's another good question. My recommendation is to report that if it's a significant event, and by that I mean a significant injury, if it's an unexpected event, if it's an event that required reporting to the state. Those would be events that I would recommend reporting in. Now, a couple of different things. If it is reported in to our claim staff, and if there is a claim representative or a defense attorney that's assigned, one advantage to that is they have the opportunity to talk with your staff while the situation is still fresh in their mind. And the other piece to that is it is always traumatic for the staff if there is an unexpected event like that. And that can be, it can be gut-wrenching and nerve-wracking for those individuals that are involved. It can also be a source of support for them during that period of time. So I definitely recommend that. If there is a lawsuit or claim that's filed, it's an opportunity for the claim staff, the defense attorney, to already have done some homework and be one up on the game if eventually we do get a claim or a lawsuit as a result of the event.
Thank you, Sally, for all the valuable insight. I just want to say thank you all for attending today. If there are any questions not answered, please feel free to reach out to any of us in the risk management department. We will have the recorded presentation up on our website soon. And for all future updates on Irwin Siegel Agency, please don't forget to connect with us on social media. Have a great afternoon, everyone.
Thanks.